My name is Nathan O'Hara, and I'm Associate Professor of Orthopedics at the University of Maryland School of Medicine. It's my pleasure to present our study published in the Journal of Bone and Joint Surgery, examining the cost-effectiveness of enoxaparin compared with aspirin for thromboprophylaxis in patients with orthopedic trauma. As background, we previously published the PREVENT CLOT trial in the New England Journal of Medicine in 2023, which compared aspirin versus enoxaparin for VTE prevention in this population. In that trial, aspirin was found to be non-inferior to enoxaparin for the primary outcome of all-cause mortality, with similar results observed for secondary outcomes including pulmonary embolism and deep vein thrombosis. Following those findings, an important question emerged. Is enoxaparin cost-effective relative to aspirin? This question motivated the current study and was funded by the Agency for Healthcare Research and Quality. Given the known cost differences between these medications, understanding their value from a cost-effectiveness perspective is highly relevant for clinical decision-making. A key challenge in this analysis was that the PREVENT CLOT trial did not directly measure costs or quality of life outcomes. To address this, we collaborated with Dr. Joseph Levy at the Johns Hopkins Bloomberg School of Public Health, the lead author on the study. Dr. Levy brought deep expertise in health economics and leveraged multiple data sources, including the CMS average sale price data, the HCUP database, market scan, and published literature, to estimate both the costs and health utilities associated with these relevant clinical outcomes. One of the most surprising findings was that the total costs were quite similar between the two strategies, despite the known substantial differences in drug acquisition costs. This is largely because patients receive thromboprophylaxis for a relatively short duration, and the medication costs represent only a small portion of the total cost of care in this population. Importantly, our results demonstrated that enoxaparin is not cost-effective relative to aspirin for thromboprophylaxis in orthopedic trauma patients. Additionally, our analysis did not incorporate patient preferences. However, previous research suggests that patients strongly prefer the oral administration of aspirin over the subcutaneous injections of enoxaparin. An interesting unanswered question relates to the evolving practice patterns. Since the publication of the PREVENT CLOT trial, we have observed a shift towards using enoxaparin during hospitalization, followed by aspirin at discharge. Notably, none of the approximately 12,000 patients included in the PREVENT CLOT trial were treated with this sequential strategy. This highlights an important gap in the evidence and suggests a need for further research to evaluate the effectiveness of this hybrid approach in VTE prevention.